Warm welcome to our presenter tonight, Belinda Kwok, who is volunteering her time to talk to us this evening. Thanks, Belinda.
You're welcome.
Thank you to Regina Hartley, our administrator. Without Regina, we would not be able to run these webinars. Thanks, Regina. Our Dizzy host this evening is Vicky Larnack. Thanks, Vicky.
You're welcome. So, Belinda Kwok is a research audiologist who performs hearing and vestibular function tests at the Balance Clinic and Laboratory in Newtown. Belinda completed her studies at Macquarie University, first with a Bachelor in Speech and Hearing Sciences in 2014, followed by a Master of Clinical Audiology in 2016. Her previous work experience involved working at Cochlear Limited as a research audiologist in product development and a clinical specialist in the Australia and New Zealand team. She's currently completing a PhD under Professor Miriam Welgampola, examining the impact of cochlear implantation on balance function. Thank you very much, Belinda.
No, thank you, Vicky, for that lovely introduction, and thank you, Anne, for inviting me. Thank you. So, so as Vicky mentioned, I'm Belinda, and I am currently doing a PhD with Associate Professor Welgampola on this topic of cochlear implantation and its impact on balance function. So, this topic is actually very new. We don't know a lot about it at the moment, and that's why we're here talking about it. So what I might do is just share a bit about the research findings that I've been getting from my research so far. I'll also do a bit of an introduction into CIs and how they work for those who weren't able to attend the previous webinars, which Professor Gibson and Selene talked about. So I do apologize if there's a bit of an overlap, but I think it's always good just to have a bit more understanding and clarity and hear things a few times. So here we go. So I'm sure most of you may already know, but what a cochlear implant is, but we'll just do a rehash. So a cochlear implant is a hearing device, which is suitable for those actually with a moderate to profound sensory neural hearing loss and who aren't actually getting sufficient benefit from the hearing aids, even though they have one. So if you look at the audiogram I have pictured here on, hopefully it's the same on your screen, the right. This shaded area is audiologically what the criteria now is for a cochlear implant. If your hearing is within that range and you have hearing aids and you're still finding that you're struggling to hear in noise, struggling to hear little kids, or struggling to hear on the phone, then those are all signs that actually a cochlear implant may be something that is suitable for you and something worth considering. So how does a cochlear implant work? So just with the cochlear implant system, there are two main components to it. So there's this external sound processor that sits outside the ear, sits on the ear outside, and it has a coil which attaches via a magnet to the internal component, which is the internal implant. So unlike a lot of people and what they think, the surgery for the internal part is actually not brain surgery. It's a very simple procedure where the surgeon just makes a cut over the skin and then they tuck this implant under the skin and then feed the electrode array into the cochlea. So it's a very standardized and simple procedure now. And usually the patient only needs to stay overnight in the hospital. So it's definitely not brain surgery, and it's nice and easy and simple. And so with the external part now, you will probably see these days there's two different types of processors which are available. So this is the traditional behind the ear one, where there's two parts to the module, this part which sits behind the ear, and then the coil. But then you may also see people who are just wearing a combined integrated one unit where everything is just in this circle and it just sits on the head there, attached via the magnet. So there's no behind the ear component. And so sometimes that suits some people, particularly if they don't like having things on the ear or they've got like glasses or things like that, but they both work the same and it's more personal choice which one you do. And so like Selene was saying in her talk, there are a number of cochlear implant manufacturers. So given my history with Cochlear, I am slightly biased to them, but not really. This is just an example I got online about what they have, but there's Advanced Bionics, Medel, and other ones as well. Okay. So before I talk more about how a cochlear implant works, I thought I'll step back and just explain how we hear naturally, because then that will flow into better understanding how the cochlear implant works and how it's better for those who are still struggling with hearing aids. So in the normal system, this is how we hear. Sound waves from the environment get picked up by our pinna, which is the outer ear, and they get channeled through the ear canal to the eardrum. So the eardrum is a very thin membrane that sits across the ear canal, kind of like cling film. And when the sound waves hit that, that vibrates. And then that causes vibrations of the bones behind the eardrum, which we call the ossicles collectively. Those vibrations are then sent to the inner ear, the cochlea, which is the main hearing organ. So in the cochlea, there are some special cells called the hair cells, which change the mechanical vibrations into an electrical impulse that gets sent along the hearing nerve to the brain, and that's what we perceive as sound. So in situations where we have a hearing loss, it's the hair cells which are damaged, so they are no longer able to change the mechanical vibrations into that impulse. And in mild cases of hearing loss or moderate cases, making the sound louder is sufficient to overcome that damage and have sound heard by the brain. But it gets to a point where the hearing is so significant and the damage to the hair cells is so extensive that there aren't many hair cells left to do that conversion. So even though we're sending sound through louder, for example, through a hearing aid, it's still going through a damaged system here. And as a result, you're not getting any clarity. And this is where a cochlear implant can be beneficial. So like I was saying, unlike a hearing aid, which just sends sound through a damaged system, what a cochlear implant does instead is that it bypasses the damaged part of the cochlea and through the electrodes will stimulate the hearing nerve directly. And as a result, it makes it easier to interpret speech, hear in noisy environments, and understand where sound is coming from, especially if you have a single-sided hearing loss and your other side is normal. So if we go into a bit more detail about how the external processor and the internal implant link up and work, this is actually what happens. So this is what we call bionic hearing. If you have a cochlear implant, is that instead of your ear, the sound is picked up by the microphone on the sound processor. That sound is then coded into signals, which are transmitted via this external coil to the internal coil, which connects to the implant that's underneath the skin. Those signals are then processed and converted to short current pulses, which are directed to the electrodes, which are in the cochlea. And these current pulses then send out signals to stimulate the hearing nerve directly. And that's how you hear sound if you have a cochlear implant. So we tend to say it's a different form of hearing. It takes time to get used to, but over time, because your brain is so plastic, what initially may sound electric and metallic actually can sound normal, and you will find it normal as well. And a lot of patients tell me that. Okay, so that's the overview about what cochlear implants are and how they work. And so you may ask, well, why are we interested in the balance then, and what connection does it have? So as you can see from this diagram here on the right, the hearing organ and the balance organs, which are here colored, are really closely located together. So you've got 5 main balance organs. You've got the 3 semicircular canals, which are the ones I've labeled 1, 2, 3 in blue. You have one canal which points upwards, which is what we call the anterior canal, one which is horizontal, the lateral canal, and one which hangs backwards, the posterior canal. So collectively, the three canals kind of act like accelerometers in your head. So they help you detect head movements left, right, up and down. And then on top of that, you've got two other balance organs called the gravity sensing balance organs, which actually help you detect movement forward and back, and also up and down. And so together, you've got these 5 balance organs in each ear. And the reason why we're interested in whether they get affected during surgery is because of how closely located they are. So there is a very small risk that since they're so closely located to the cochlea where the operation is being done, that there may be a chance that they are affected. And so in the clinic where I work, we like to check patients' balance function before surgery and after. And the reason we do that is there's a few reasons. So the pre-op assessment actually gives us a baseline indicator of your balance function. And secondly, it tells us and helps us check whether the ENT needs to make a decision about whether to change the ear that needs to be implanted. So this only will arise in the situation, for example, where you have a good balancing ear and the other ear actually has poor balance. So if the ear in which you want to implant turns out actually to be the ear which has good balance and your other ear is poor balance, then we don't actually want to run the risk of actually possibly impacting both balance organs afterwards, given there is that small risk. But what I do want to say is that in a situation where you have hearing loss in one ear and the other ear is totally fine, then even though it may be that the balance organ is impacted in the other ear, the benefit that you get from the cochlear implant far exceeds the balance loss. What it does do is that it does guide us in knowing what steps we do need to take to help you to regain your balance after surgery. So it's actually just a very good indicator to have an underlying understanding of how your balance function is before the surgery. And then we tend to check it 2 to 3 months after surgery to see if there has been any change in the balance organ function. And so based on that, you might say, well, what are the tests that we do and what's involved? So I'll just give a brief overview about what you can expect that I do if you do come see us for balance function testing. So like I said, there's 5 balance organs and there's 5 tests that correspond to them that we can use to check the balance function. So it takes around 45 minutes because we do go through all of them. And now I'll just go through in detail the 2 main ones. So the first test that we do is the 3D video head impulse test. So this is in short form known as 3D VHIT. And this first test checks the first 3 balance organs that I was talking about. So those semicircular canals, so these little rings here. And we check it based on the fact that we get an automatic reflex that makes your eyes move when we turn your head. So as you can see on the picture in the right here, what happens during the testing is I pop on a set of goggles onto you and I get you to fixate on a fixed point. So I have a target on the wall, which is just a dot, and patients say, that's a lovely piece of equipment. And so I get you to fixate on that whilst I move your head left and right. And what will happen in an intact balance system is that when I'm moving your head either to the left or to the right, your eyes will actually have an automatic reflex where they will pop back immediately in the opposite direction, such that you can maintain focus on the target. And that's a reflex that we all have. If that reflex is damaged and we don't have that reflex, then what will happen is that when we're moving, walking and running, our visual field will be bopping up and down. So if we see that reflex, what we get is a response that looks like this on the far right here. You get the black line, which is the head movement, and the blue line, which is the eye movement, overlapping exactly on top of each other. And so that was a test to check the horizontal canal, me moving your head left and right. And then if I want to check for the vertical canals, so the posterior and the anterior, what I'll be doing instead is tilting your head up and tilting your head down to see if I get the same reflex. So if I tilt your head up, I'm expecting your eyes to quickly come back down to focus on the target. And if they are, they will overlap like this. And if I'm checking the other one, tilting your head down, I would expect your eyes to pop back up quickly such that I get this response here. So that's the first funny test I do. So this one has a fair bit of quick head moving. And if you come with your partner, I will always tell them that it looks worse than it actually is. Okay, so it's nice and safe. It just looks and feels a bit weird. So the other funny test that we do is called the Vestibular Evoked Myogenic Potential, short form known as VEMS. So this test checks the gravity sensing balance organs, so the utricle and the saccule. And once again, it relies on a reflex muscle response. So to check for the utricle, we actually measure a reflex response from the muscles which underlie your cheeks going up to your eyes. So what will happen is I'll be popping a few stickers on your cheeks and one on your chest to measure that reflex. And the reflex gets stimulated when we activate your balance organ through some loud clicking sounds, which I'll present through headphones, and then a different one, which is a bit of a funny one, a tapping sensation on the top of your head. And so all you need to do in this test is just sit still and have your eyes looking up. And then if that reflex response is present, then I get a peak and a little trough on these traces that are recorded. So that's the reflex that we want to see. And in a similar fashion, for the other test to check for the saccule, this time the reflex response comes from the neck muscles. So I'll be popping some stickers on either side of your neck and on the top of your chest. We'll still use the same stimulus, so the loud clicking sounds and the tapping. And this time, all you have to do is you'll actually be lying down first. I'll get you just to lift your head up off the pillow and turn either to the left or to the right during the testing. So I often joke with patients that it's a bit of a exercise in going to the gym when you come to see us, because at the end of it, I think you'll have a very good workout. Okay. So that's a bit of an overview about the testing you can expect to see and the testing that we do. Now for, I guess, the interesting part, which is what everyone here is probably keen to know about, is actually what do we know about dizziness and cochlear implants at the moment? So like I was saying to Anne earlier, this area is actually very poorly researched at the moment. There is not much out there. What we do know from the overall literature is that dizziness is quite common after surgery. There is an average prevalence rate of around 9.3%. However, this dizziness is usually mild and is typically characterized by unsteadiness and lightheadedness. And it's also generally short-lived. So it usually occurs soon after surgery and resolves within a month. Okay. There are instances of severe attacks of vertigo, but they are rare. And these type of attacks of vertigo are actually quite similar to what you guys would actually have experienced in the Meniere's attacks. So they tend to be the longer episodes accompanied with nausea and vomiting, but they are rare. The majority of dizziness that you do get following cochlear implant surgery is brief, just happens after surgery and abates after a month. But in saying that, there is very limited knowledge that we have about this area. And so that's why we're here to do more research and understand more about it. And so what we did in our lab is that we actually had a look at what the impact of cochlear implants are on the balance organs, which I just described to you, and on what patients rated as a subjective dizziness. So this is a paper which we just published earlier this year. And now I'm just going to present some of the key findings from it. But definitely, if you're interested to have a closer look at the paper, more than welcome to send it to Anne, and then she can disseminate it to everyone if you're interested. Okay, so what did our study involve? So our study had 72 patients. And what we did was with these 72 patients, we saw them before surgery for the full vestibular workup. So we checked and did all the testing to check the function of their 5 balance organs before the surgery. And then after surgery, we brought them back and did the same thing. and that was to check any change in the balance organ function. We also wanted to get an idea of how they felt the dizziness was like and whether that changed whether that changed after surgery. And to do that, we gave them a questionnaire to fill out, which is the dizziness handicap inventory before and after the surgery. So the dizziness handicap inventory is like a questionnaire that just tries to quantify how handicapped patients feel from their dizziness. So it asks questions like, does looking up increase your dizziness, or because of your dizziness, do you feel frustrated? And then the patient just has to tick yes, sometimes, or no. And there's a scoring that's ascribed to each of these responses. So yes gets the most marks of 4, sometimes no, sometimes 2, and no gets 0 scores. And then at the end, I tally up the scores, and there's a DHI score. So the higher the score, the more dizzy the patient feels, or the more they're saying that the dizziness is affecting their daily life. So what did we find? So we'll start by having a look at the patient demographics in our group. So as I just said, we had 72 patients in total. 29 were female and 43 were males. The average age at post-op testing was 59 years old, and the average time at which we undertook the post-op testing was 197 days post-surgery, or if it's easier, 6.5 months approximately after surgery was on average when we saw these patients. And so on the right here in this table, you can see the cause of hearing loss, which led these patients to get a cochlear implant. And you can see that Meniere's patients actually make up a big proportion of the people in my data set. So the other ones which were quite common were those that had a progressive sensory neural hearing loss, or those that had a sudden sensory neural hearing loss. So definitely Meniere's patients do go ahead and get a cochlear implant as well. And we had 11% of our population being comprised of them. So now for the part which you're all waiting for. So if I look at the impact of a cochlear implant on the subjective ratings of balance by looking at any change in scores on the dizziness handicap inventory, what I found was that actually 50% of patients had no dizziness before surgery and then also reported no dizziness post-surgery. So these patients basically were normal before and stayed normal after. 18% of my patients actually had a pre-existing dizziness, but they also had no significant change in their dizziness after surgery. So in other words, the cochlear implant didn't actually damage anything or make anything worse for them. In 12% of patients, it was quite interesting. They showed a significant improvement. So they actually said that subjectively, their dizziness was better after surgery. And only in 19% did patients report new or worsened dizziness. So now if we have a look at the overall impact on the various tests of balance organ function, we can see that actually 39% of patients showed no change on the 7 vestibular function tests that I conducted. So before surgery, they were normal, and after surgery, they were normal too. 44% of patients showed a mild change. So what that meant was out of the 7 tests that we did, they showed abnormalities on 1 to 2 of the tests after surgery. And 13% showed a moderate change. So out of the 7 tests, there were 3 to 4 tests which showed abnormalities. And only very few, 4%, showed a severe change. And these were the ones which had 5 to 7 out of the 7 tests showing being affected. So overall, you can see that actually majority of patients either have no impact or just a mild impact to their balance organs. And now if we look specifically at the 5 balance organs and see which one of them were impacted, we can see actually that out of our patients, only 10% had this posterior canal affected, 13% had the anterior canal affected, and 17% had this lateral canal affected. So pretty much they're quite even. And then if we're looking at the other two balance organs, we only had 7% of patients with the utricle affected and 10% of patients that had the saccule affected. So as you can see, the rates are very low here for these organs. And now to tie it all together, you may ask, well, how do the objective tests relate to how patients report about the subjective ratings? So it's not surprising that we did find that as the number of balance organs affected increases, we do also find that the DHI scores also increase. So basically, the more balance organs that are affected, the worse the dizziness handicap that patients report. And so in summary, we can see that dizziness can occur post-surgery, but it is mild. And in our case, it was 19% of our patients that had dizziness. The damage to the balance organs is also minimal. And in our study, the maximum damage was 17% of cases. And what I do want to emphasize is that actually the majority of patients did report no change in their preoperative state or didn't report any dizziness after surgery. And in our study, if we look at those together, that was 68% of our patients. So the majority actually have no impact onto the dizziness and don't report any change in their dizziness at all. So, I mean, I know you're all concerned because I did say there is a bit of dizziness that you can get after surgery, and you're worried about, oh, what happens and what do I do? And I want to reassure you that there is help available. So if you do get dizzy after surgery, and it's been more than a month and it hasn't abated, then definitely see your ear, nose, throat specialist. So we often, the ENTs that we work closely with in our clinic are very good. If they see anything that warrants further investigation, they will send patients to us straight away. But you can also just see us for a post-CI assessment and examination. So Dr. Welgampola, who I work with, is a specialist in seeing dizzy patients, and our daily clinic is just comprised of seeing dizzy patients. So there's definitely treatment and exercises that we can do to help you depending on the cause of your dizziness. So don't feel like there's nothing that can be done. There is definitely things that can be done and things we can help you to optimize your dizziness if indeed you get dizzy after surgery. So, I mean, I just have a little take-home message just to wrap up everything. I know a lot of people, when they think about going for a cochlear implant, do get worried about a lot of different things. And it's definitely an important decision and one which warrants thorough thought. But I do want to remind you and encourage you to remember that if you are finding that your hearing is at a point where hearing aids are no longer helpful and a cochlear implant is the only thing that can improve your hearing, then I don't think that there's anything that you have to lose, especially if you're concerned about how it impacts your balance. Actually, the impact is minimal. And if indeed it does cause a deficit to your balance functions, there's things that we can do to help you to optimize your balance. So in our clinic, we do see patients who have had completely their balance organs wiped out, not because of a CI, but because of just general a viral infection has affected their balance function on one side, but they are able to regain their sense of balance and optimize that through a set of exercises we give them. So there's definitely things that can be done about your balance if indeed it is affected, but only a CI can improve your hearing. So if we don't take that step and that's something that you really want to achieve, I guess the benefit of getting a CI far outweighs any risk of impact to your balance organs. So I just wanted to end on that note. And that's actually all that I had for today. I do have a page of references if you wanted to look at some of the studies I mentioned. And this study is the one that I presented on, but definitely opening the floor up to any questions that you may have. And like I said before to Anne, because this area is so new and we don't have that much research yet, there may be questions which we won't be able to answer, but actually you're probably going to give me inspiration for future research. And I did want to mention actually some of the other things that we are working on looking at in terms of cochlear implants and balance function is actually trying to build a big database of probably more than 200 patients who we've seen pre and post-op to actually work out what are the factors which may make people more likely to get dizzy or less likely. So we want to look at like medical factors, demographics, surgical technique, and whether any of those play a role in influencing the outcomes in terms of balance for a cochlear implant. Yeah, so I just wanted to conclude with that. And if you have any questions, I guess I'll hand over to Vicky or Anne to moderate that, and I'm more than happy to answer anything.
Yeah, we do have a couple of questions. Here's one from Anne. She asks, why do Meniere's patients get better results?
Yes, so the main reason for that is because actually in Meniere's patients, the hearing loss or the part which gets affected is actually in the cochlea. So Meniere's happens when there's a buildup of fluid in one of the chambers in the cochlea. And so it's only affecting the hair cells. And what the cochlear implant is reliant on for good results is a good intact hearing nerve. So in Meniere's patients, your hearing nerve is actually intact and well, unlike other causes of hearing loss where there may be a component that the hearing nerve is affected. So that's why in Meniere's patients, because the damage is actually done exclusively in the cochlea, there's very little impact to the hearing nerve. And so that's why we do tend to see that they get better outcomes. Yeah.
Similar to that question was from Marie. She asked, were the 8 that reported improved balance Meniere's patients?
So one of them was a Meniere's patient. And actually that patient, along with reporting improved balance, when we checked the balance function, they actually had lost all their function. And that's kind of like an example of what Professor Gibson would sometimes talk about. If you ablate the balance organs, the patient actually ends up feeling better. So not all of them were Meniere's patients, but there was one who actually reported improved subjective balance, but actually had all their vestibular organs actually affected. Yeah.
And Anne also asks, can you talk about bilateral implant research, please?
So that's probably I have to do another research project on. So this particular study was just on unilaterals. But yes, we do have bilateral patients coming in, and that is also a really big topic because, and it's also the reason that has inspired us to look further into what impacts cochlear implants can have on the balance function, because with the increasing numbers of patients that are getting bilaterally implanted, we really do need to get a better understanding of what the cause is and if we will cause patients to actually have a bilateral balance loss. And I mean, based on the data we have now, I can just speak anecdotally from like some patients that I've seen. So I do see patients that are coming to me for a pre-op assessment for their second one. Generally, if they've gone well with the first one and there hasn't been any balance function loss, then we say go ahead. We don't expect there to be any loss afterwards. But if they do show from the first cochlear implant that they've had some balance function, then we are a bit more wary to advise about whether to go ahead or not. But it's really dependent on the patient and also dependent upon, I guess, the pre-existing cause of hearing loss and a whole range of factors. So it's not a straightforward answer that I can give, and also one which has not yet been kind of fully looked into, but definitely worth investigating.
Another part to a question from Anne, have you come across anyone unable to learn the new signals?
So I must say that when I see patients, I see them specifically just for like balance function testing, and it would just come from me talking to them. So maybe if Selene is online because she sees them routinely, she will be able to talk a bit more in detail about that. But I would say that most of the patients that I have seen post-op, they have all been able to adjust to it. And when I worked at Cochlear in a different research role, and I also saw research participants that had the cochlear implant for a very long time, they've all told me that they've been able to adjust to it. So people are different in terms of how long it takes for that adjustment. But most people are able to just intertwine the two because the brain is so plastic. You will definitely transition from the phase of when it's electric to becoming more and more natural. What is natural, I guess, differs for everyone, and what they accept as natural is different, but definitely, like I've asked that question to the patients before when I first started, and I was curious, and they said, no, it becomes natural. And the same if you get a bilateral implant, then the two will actually mold together. So the brain is much more plastic than you think it is. And it's definitely more than capable of helping you integrate the sounds. We do know that what you can do to help yourself to better adjust to that is actually listening to the sound more. We find that those that actually don't listen with their cochlear implant that much are the ones which are probably going to struggle to adapt to that new signal.
I have single-sided hearing loss. That ear has severe hearing and balance damage. Would a cochlear implant help the balance function and dizziness?
So I think that's a very interesting question, which I recall actually Professor Gibson talked about in his previous talk. And I remember the answer that he gave was that actually the CI, I guess, is kind of independent of balance function in terms of helping it. So it is possible with many as patients that even with a CI, you could still get dizzy. You mentioned you had single-sided hearing loss and balance damage. I suppose, have you been diagnosed with Meniere's, or it's just a diagnosis of single-sided hearing loss with vertigo? So I do also see, like in my data set, I also did have patients who had single-sided hearing loss and vertigo, which I'm assuming you're saying if you had balance damage. But I think the two are independent. I wouldn't say that the CI helps the balance function and dizziness. Like I can't claim that it will stop it because I think it has the cause of the original hearing loss and the damage has its own trajectory. But what the CI can do is actually give you that hearing and that localization of sound, because with a single-sided hearing loss, what I gather you're probably, one of the things you're struggling the most with is that you actually can't hear where sounds are coming from. And this was something that Anne shared with me before. And in this situation, only having a cochlear implant there will give you that awareness of sound and being able to detect where sound is coming from. Sorry, the awareness of sound on your ear, which has been deafened, can still be obtained by other means apart from a cochlear implant, for example, like a Bicros or a Baha. I'm not sure if you're familiar with those technologies, but some other options for patients with a single-sided hearing loss is a device called a Bicros. It's literally just like it looks like a hearing aid. So it has a receiver on the side of your ear where you have the severe hearing loss, but the receiver picks up the sound from that side and actually transfers it to your good ear, where you also have another device which looks like a hearing aid, and you hear the sound from your deafened side in your good ear. So it's a bit of a complicated one to describe, but basically what it does, it routes signals from the sound side that you can't hear from to the side that you can hear from. So just say I was deaf in my left ear and my right ear is good. It will pick up sound from the left side, but I'll hear it in my right. So it will give you sound awareness. So I'll be able to hear what is happening on my left, but I won't be able to say where a sound comes from. So if a sound came from behind me, I wouldn't be able to say it came from behind. I would just hear it somewhere. And so that's another option for patients with single-sided hearing loss. But if what you're looking for is being able to identify exactly where sound is coming from, something we call sound localization, then that can only happen if we have two ears, two working ears. And that's where the cochlear implant can give you that. So yes, it's a really personal choice about what works. With the bicross, it's something you can trial as well. So you can try it out and see if it's a viable option. But if it's still not meeting your goals and you want to be able to hear on that side, then definitely a cochlear implant is something worth considering.
Questions? So Belinda, if we haven't seen you prior to the operation, can we come across and visit you after the operation for exercises and etc.? Yep. People can come and see you. Yeah, no problem.
Yeah, that's fine. And normally I only do the exercises if I see that there's a drop in your balance function. And majority of the cases, patients come post-op with no balance function, with no balance loss. But if, for example, you do find that you're dizzy after a month and you're like, oh, has something happened? Come to us. But even in the absence of that, you're more than welcome just to check your balance function with us, because that also gives you a peace of mind so that you know if you do consider to go ahead with a second cochlear implant, if that ever is required, then you have a baseline function. So the thing is, not all ENTs do a routine pre-op assessment. So the ones I work with do send their patients, but it's not, at the moment, it's not standardized practice, which I'm trying to change and hopefully encourage everyone to do that. So definitely would recommend and encourage a pre-op and post-op assessment, but it's okay if you haven't done it, especially given it's quite clear which ear you're going to implant. It doesn't really play a role in determining the ear, but it really does give a good baseline understanding. So we know that what to go off when you come to see us post-op.
So a lot of people aren't aware of that, are they? A lot of people in our world aren't aware that they.
Yeah, so it's a bit of
testing for, pre-op, no one knows that.
Yeah, so that's why this research is still so limited, because I think at the beginning when cochlear implants came up, the focus was on the hearing, how is the hearing before, how is the hearing after? And I think now we've reached that and we know that cochlear implants can make such a big benefit. Now it's time to really look into, how does it impact the balance? And that's what my whole PhD is about. And I think it's just only going to touch the surface of what is yet to come. So yeah, it's just great to be able to have a role to get the ball rolling.
So is this on your website that people know that they can come and see you, pre-op and post-op? Is this, so how do people know? That's what I mean. How do we know this? I had no idea you were doing this.
Yeah, so at the moment, it's just been referred from the ENTs, but that's a really good point, which I should raise with Miriam. We should just pop it on our website. So, I mean, we do talk about, us doing research in the cochlear implant space, but definitely, that's a very good point that you make. I can definitely ask her to update the website and make it nice and clear for everyone. Yeah, even if it's for your own personal reference. Yeah,
that's it. Yeah, and also for research. So it's great. Yeah, it's really good. Any more questions, anybody? Oh, got a lot of thank yous here, Belinda.
You're all welcome. Thank you for listening in at 7 o'clock.
Yeah. Okay, well, thank you everyone thanks Belinda, number one, thanks for volunteering your time. This is really informative. It's
very good to hear. My pleasure.
Yeah. Thanks, Regina, as usual. Thank
you, Regina.
Thank you, Vicky.